But if we're here to talk about, Indigenous health service equity, this is really where it starts and ends. So, I'm here to talk to you about the Indigenous patient journeys. And that's an examination of what is working, what is not working, and what is missing in addictions and mental health services delivered to Indigenous folks. Why do we need an Indigenous patient journey? Well, we have UN Declaration on the Rights of Indigenous People, UN DRIP, 2007. We have Creating Connections, which was our addiction and mental health strategy. We had Patient First Strategy 2015. We have TRC 2015. We have the Mental Health Review in 2016. So what am I saying here? I'm saying that government after government, provincial or federal, year after year, we talk about improving services to Indigenous folks, but it just never seems to happen as much as we wish it would. So what happens when we design services without consulting service users? Well, service users will always go the way that works for them, even if it means not accessing services at all. So it's important that we listen to service users, but it's imperative that we learn from them. Okay, so this project, we interviewed over 200 Indigenous service users across Alberta. We looked at 100 incarcerated Indigenous service users. There was a current state analysis and a gap analysis combined into a single project. Like I said, we set out to find what was working, what was not working, and what was missing. We set out to capture the service user's perspective on AMH service, the service user narrative. How did the projects go? So, Ipj 1 started in July 2015, it concluded in January 2016. We interviewed in 13 locations, you can see by the arrows there. Typically, the community-based service organizations are support services, treatment centers, or even on-reserve health centers. Ipj 2 started in 2016 and went all the way to August 2016. We interviewed at 7 correctional centers across the province. With the first project, it was, the challenge was finding people to interview. Ipj Demographics. So for Ipj 1, we had participant demographics. We had an end value of 100, convenient sample of 50 males, 50 females. An average age fell between 40 and 49, 73% status. Now these guys had multiple episodes of inpatient care, both in addiction treatment and also mental health treatment facilities, predominantly homeless individuals. Ipj 2 was much the same. Of course, they're all incarcerated. We looked at 6 key areas. We looked at service awareness, service access, service delivery, and the availability of culturally safe services. We looked at service transitions. But above all, and perhaps most importantly, we looked at trauma, or rather trauma exposure. Understanding the Indigenous service user starts with understanding the service needs. Adverse childhood experiences. Looking at is everybody here familiar with adverse childhood experiences? Right? Okay, so Dr. Vincent Felitti looked at 18,000 people, found a huge connection between trauma exposure at young ages and then addictions and mental health problems later in life. Found impaired brain development. So our trauma inventory was definitely inspired by Felitti's, but we wanted to go a step further. We wanted, as those of us that work with vulnerable populations know that trauma doesn't stop on your 13th birthday. It usually carries on. And we wanted to look at how does that carry on? What does it look like? Does it go up? Does it go down? So we looked at not just their childhood, but their teenage years, and we looked at their adulthood too. So after studying the adverse experiences and the trauma of 100 high-need service users, we saw 2 patterns emerge. The first pattern is that trauma was most common in these 7 areas: abuse, mental, physical, or sexual, family tragedy, accidental death, suicide, homicide. This is missing and murdered women, right? This is what we're talking about here. mental health problems, physical health problems, relationship breakdown due to family violence, divorce, separation, foster care, or parental incarceration. And we talked about relationship breakdown with friends, dysfunctional relationships. The second pattern was that the level of adverse experiences and trauma in these 7 areas increased with age. But in each one of these rings, there's supposed to be 3 rings, and in each ring, those numbers go higher. That means that the abuse went higher in their teenage years, the abuse went higher in their adult years, mental health problems got worse, physical health problems got worse, relationship breakdown got worse, substance abuse absolutely skyrocketed. We looked at this and we kind of thought, this is as bad as it can possibly get. These are the highest service users there are. And we were absolutely wrong. When we looked at the correctional population, we actually saw that the numbers in every one of those categories was, in some cases, double. It was actually a lot higher. Substance abuse in adulthood jumped from 88 to 98. That's 98 out of 100 people saying they had a substance abuse problem. Mental health jumped from 76 to 95. So it's clear corrections population was actually an even higher needs population. When we think about adverse childhood experiences in the correctional population, it actually comes as no surprise that they were asking for help at a younger age. Corrections population first accessed services between the ages of 13 years old and 18 years old, compared to 16 years old and 21 years old among the high-needs service users. Correction participants who accessed services before age 12 was double the high-needs service users. And in terms of mental health awareness, upwards of 95% of the 200 people that we interviewed had poor mental health literacy. We would quite often ask them, have you had any issues with mental health? And they would say, no, I'm good, it's all. And you'd say, never had kind of issues at all? No, none. It was only when we said, have you ever had suicidal thoughts? Have you ever had an anxiety attack? Have you ever been depressed? That they'd say, yeah, I've had those things my whole life. So there's a real pushback when we talk about accessing mental health services, because in most cases, mental health problems in the Indigenous populations are normal, right? We all have family members that are living like this each and every day, or we work with people who do. I'm not sure what happened with all my graphs here, but they're all over the show. When we look at barriers to service access, we see transportation as a real big issue in both of these cohorts. Out of 200 people, 158 people said transportation was a barrier to service access. Something as simple as getting a ride. When we also see a lack of personal ID is a real big barrier to service access, and even more so in the corrections population. In fact, one person I interviewed in prison said that when he was released from a correction center, he went to go get his wallet out of his possessions, and they said, you can't have your wallet unless you show us some ID. And yeah, you know, we can laugh about it now, but this is the kind of systemic barriers that are in place for a lot of these people. The absence of a family doctor or a GP, we actually talked about that earlier today, right? If you don't have a GP, you can't get a medical history. You can't get a medical history, you can't get into treatment. All of these things are connected. Yeah, right. And healthcare cards, right? If you don't have ID, you can't get a health card. Can't get a health card, can't get health services. So all of these things are connected. All of these barriers are real. When we asked both samples what worked well for them in terms of addictions and mental health services, the results between corrections population and the high-needs service users were very different. The high need service users and the correction service users value clinical staff that were understanding above all else. When we think about the trauma exposure in the corrections population, it comes as little surprise that the corrections population put a greater emphasis on the importance of staff being understanding. These are people who know what their needs are, and these are people who know what they need in a service. And it's only when we start to listen to these people that we could create, design, and develop services that'll work for them. The corrections population will put a lower value for whether or not they perceived addiction and mental health services to be sensitive or responsive to Indigenous peoples. Now, if we consider the vast majority of Indigenous people accessing addictions treatment programs or accessing programs through NADAP or through an AHS service provider that happens to be quote-unquote Indigenous, we would expect that a hell of a lot more than 41% of them found those services to be culturally appropriate. So what am I saying? I'm saying it goes a lot farther than hanging a dream catcher in the lobby, if that makes sense. While we have made huge strides in addictions and mental health services, we have a long way to go. So we're talking about service transitions here. The corrections population reported higher values for difficulties in all categories of service transition. Transition is a really, really stressful time, whether you're talking about addictions or whether you're talking about mental health. Those transitions out of services are you most vulnerable in terms of relapse. Discharges from treatment centers with homeless people are quite often happening where homeless people have nowhere to go. Okay, we heard stories of people being dropped off at bus depots. We've heard people being released from correctional facilities and being dropped off at bus stations as well. The uncertainty, the vulnerability, the substance abuse history, and the obvious socioeconomic factors make robust transition planning all the more important. And really, when you think about the dollars and cents of it, the amount of public tax dollars that are invested in health service delivery and addictions and mental health treatment, only to kick them out the door when they're most vulnerable to relapse, just does not make economic sense. So what did we learn? Well, the Indigenous patient journey cycles. So basically we identified a theme, a reoccurring cycle of what happens with all 200 of these high need service users. The Indigenous person obviously typically had high levels of stress, as we talked about previously, through their teenage years, their adulthood, their childhood. Add to that the socioeconomic factors, things like education, unemployment, housing, health, discrimination that we talked about here today. Problems with the justice system, right? Systemic racism, inadequate social supports. Add to the next mental health and addiction issues. And then obviously barriers to service access. We talked about ID, we talked about transportation. There's huge waiting lists. There's a lack of culturally appropriate or sensitive services. So let's say they make it to AMH, addictions and mental health treatment, or they get incarcerated. Once they're there, there's no trauma-informed care, there's no culturally sensitive services. Indigenous staff, elders, persons of lived experience are few and far between. There's limited transition planning. There's very little family involvement in those care plans. There's limited staff. And then they get discharged, they get released. There's very limited aftercare, limited supports, and they have no ID. They have limited transitional housing, limited family supports, maybe homeless. Add to that again the socioeconomic factors that got them there in the first place, mental health and addiction. They relapse or they commit crime, and the entire cycle repeats itself. We had most of these people that we interviewed had gone to addictions treatment 5 and 6 times, had been incarcerated upwards of 6 or 7 times. So it's a reoccurring cycle, and it's when we start to look at how services are delivered that we're going to put an end to this. What needs were identified? Well, after 200 interviews, we came up with a list. There's 67 in total. So these themes are actually service needs, or what I like to call opportunities for enhancement. We're not going to be able to deliver direct results to all 67 of these, but obviously what we can do is look at initiatives that can give us the best bang for the buck, tick off as many boxes as we can. The first one deals with service navigation. And I'll just read this quote here from a lady from Calgary. Yes, I was aware of other services. I've been sent to so many places to get help that they send me somewhere else. It's frustrating. It makes me want to explode. It gets me into trouble. That's why I got banned from a lot of these places. Many of the pilot projects we recommend are starting to happen right now. We're starting to see more service navigation staff in the hospital. Valuing Mental Health Action 6 has committed to using peer mentors as navigators. AHS is also in the process of streamlining navigation. But we are looking at other opportunities as well. Recommendation 2, we talked about trauma-informed care. Now, I'm sure a lot of you today are familiar with trauma-informed care. I'll just read one of these quotes here from a lady in Calgary. It's all about employees using power and control. I was waiting in line for detox for 3 hours. When it was my turn to go up, the lady recognized me from an argument we had the week before, kicked me out. Or this other lady who said, I talked about residential school to a counselor once, only once. She told me it was in the past and I needed to get over it and move on. So not really consistent with trauma-informed care. Of the 200 people that we interviewed for this project, 41% were residential school survivors. 75% of the participants had a parent or parents who were in residential school. The legacy of residential schools is alive and well, and the residential school survivors had children who are now middle-aged adults, coping with the effects of intergenerational trauma. But moving towards trauma-informed care is understanding that a lot of the people that we serve in addiction to mental health have suffered extreme levels of trauma and carry that trauma with them each and every day. So we talked about rural and remote communities as well. Okay, we've talked to people in the far, far north where, we're telling these single moms who are struggling with suicidal thoughts, oh, just come on in. We'll hook you up with a counselor and we'll get you right. Well, in some cases it's a 45-minute drive and they have 4 children in total, no babysitter. So we need to have realistic conversations about how those services are delivered, how we can create better access to addictions and mental health services for those rural and remote communities. So we talked about the possibility of utilizing technology, but this is still very much a challenge that we're working to improve. Obviously, it's especially true in the Indigenous communities when we talk about barriers to service access. Communities like Musqueam, from December 2017 to January 2017, had 14 suicides. Right, in a community of just over 6,000, I think it is. So I live in a community called McConaughey, just over 6,000, and you can imagine the outrage. That would be a national outrage if there was 17 or 14 suicides in my neighborhood over Christmas holidays. Why is this not an issue? Why isn't this consistently front-page news? And until we start looking at rural and remote communities in terms of addictions and mental health, we're going to continue to see these suicide clusters that we're seeing in northern Ontario, northern Saskatchewan, and right here in Alberta. Elders and cultural programming. When we asked elders with high service needs and recovery, what factor changed for you? What factor helped you stay on the right path with sobriety? 22% said it was treatment. I went to treatment. 22% said it was family and friends supporting them. But 35%, by far the biggest percentage, said it was culture and spirituality that gave them the strength for sustained recovery and sobriety. It only makes sense that we look at that as a strength. It only makes sense that we begin to implement that as part of our service model when we talk about addictions and mental health services delivered to Indigenous people. Cultural competency is now mandatory for all AHS staff, with the exception of doctors, who are mostly contractors. So it starts with culturally safe services. We need to see more elders. We need to see more cultural programming. Service transition staff and aftercare. This lady says they should have done follow-up and home visits so people don't feel so alone after they leave treatment. We give up a lot of our friends and family when we give up alcohol. And it's time we start to look at more effective transition from one service to the next, things like transitional housing. We need to look at more of what I call the 3 C's: communication, coordination, and collaboration with community-based organizations. We need to stop working in silos, start working together. Aftercare needs to become a bigger part of our service modality. The Value Mental Health Next Step Action 1 has committed to supporting youth and young adults in transition, so we should start to see tangible results in these areas. Transition beds like E4C in Edmonton and Fresh Start Recovery have started to open up. And I think now more than ever, we're starting to see that social return on investment. And I think for the longest time, we were trying to convince the other side that upfront investment in prevention was going to make sense, just because the numbers would go down. I think now we're starting to realize that it really is about social return on investment that's going to bring people to the table. When you can say, we invested $3 million in Ambrose Place in Edmonton, but we saved $14 million for taxpayers because they didn't go to emergency rooms as much, they weren't incarcerated as much, they weren't in hospital beds as much, and the ambulance didn't come out as much. Harm reduction is an essential resource in the fight against homelessness. In some cases, it's the only way health services can consistently engage the service user and provide care for chronic physical health conditions. Okay, these are high needs chronic health conditions that are constantly filling up our medical and surgical beds in the hospital, creating longer wait times for everybody else. If we can find a way to not lock them in, but give them services in place to keep them out of ambulances, to keep them out of emergency rooms, to keep them out of the medical surgical beds, the cost of health goes down, and ultimately people get the services that they actually need. So that requires, in some cases, harm reduction. We're starting to see more harm reduction beds happen. When we're talking about places like Ambrose being harm reduction housing, we see that the residents were able to achieve a 31% decrease in emergency calls, an 81% decrease in days spent in the hospital ward, and a 58% decrease in hospital admissions. Most of the recommendations that I made coming out of this project were adopted in Valuing Mental Health, which is the Alberta Health Services mental health strategy, essentially. A number of these recommendations were included in the Calgary Recovery Services Act and endorsed by multiple ministers. And now it's kind of been evolved into different working groups. But over the years I've been doing this and presenting this information, you're starting to see it pop up a lot more in literature reviews. You're starting to see people make reference to this report. If we continue to spread this information organically, we have a chance at making a big difference in the long term. So moving on to Ipj 2, I'll just really quickly go through some of these because a lot of these are more pertinent towards corrections. Recommendation 1 there, I said that the Young Offender Patient Journey Project. This gentleman from Lethbridge says, why aren't the addiction and mental health services trying to help people when they're young? Why do they wait till they're in the system when it's too late? That really rang true to me. That made a whole lot of sense. What the hell are we doing? Why are we waiting for this to become a problem? Why aren't we getting ahead of it, getting ahead of the curve? So we're saying there that we need a Young Offender Patient Journey Project. Project to identify what's working, what's not working, what's missing in services delivered to our Indigenous youth. Indigenous diversion teams. Now, if you remember when I talked about mental health literacy, you know that a lot of these guys, 90% of these guys, said they had no problems with mental health. So what happens if you get charged with a criminal offense with diversion? Well, if you get successfully referred to diversion, you're going to get treatment instead of going to jail. But what if 95% of the Indigenous people that are referred to diversion stand up and say, I don't have any mental health problems? They're not going to get diversion. Which is why 98% of the people that I interviewed in corrections had addictions and mental health problems. They shouldn't be in corrections. They should be in treatment. And we should know the difference. So what I'm saying here is that we need more Indigenous diversion teams. We need Indigenous clinicians that can engage Indigenous service users. There's one so far that I'm aware of in St. Paul, and since she became operational, they went from like 2 referrals a week to about 60. So that really speaks to the need and to the utilization. People quite often scoff when I say how important Indigenous staff is. And Indigenous staff need to form a partner or service delivery if we're going to be successful with Indigenous people. And here I just kind of talk about Indigenous mental health diversion staff. It's pretty much the same principle. Increased access to elders in center. We talked about this guy here from Lethbridge says, I think services need to be rooted in culture. Indigenous people, most addicts do not have families, so you need something to connect to your sobriety. We talk about the importance of spirituality and culture when we're trying to engage Indigenous populations. I talked to one guy who said, they have somebody in the basement, or they have a church in the basement for non-Indigenous people, but they don't have a gathering place for Indigenous people. Or we talked to another guy in Fort Saskatchewan Corrections who said, they have a priest come in here and talk to these white guys 7 days a week, every day. But we only get the elder 1 day a week. Why is that? And where does it start when we talk about equity and health service delivery? It's got to start somewhere. So we're working on that. We're working on a number of these different initiatives. Persons with lived experience. And when you're talking about improving health services, everybody seems to think it's going to be this, or it's going to be that. What I found to be true talking to the actual service users is that there is no one answer. There's about 4 or 5. And one of them is persons that live with experience. Persons with lived experience. They want to know somebody, they want to talk to somebody who's been there, who understands that, who understands the challenges. And then the next person says, that's not for me. I prefer somebody who's never had an issue and has more credentials behind their name. It's not going to be one size fits all, not with a group this complex. Trauma-informed care training, again, obviously that's important in corrections. That was there. I was going to read this one, this guy from Lethbridge here. Talking to him about trauma-informed care, whether or not he thought health services were trauma-informed. He says, no, not at all. I seen a friend die, nobody ever asked me about that. My wife hung herself in 2003, nobody ever asked me about that. It's because nobody wants to listen. The very basis of trauma-informed care is that we start to listen. So this is more about staff. We have there was no consistency in all the corrections, and the different correctional facilities that we went to. One facility would have 500 people, 500 Indigenous service users, and they would bring in somebody 0.5 a week. Another facility would have 1,000, and they would have somebody coming in 1 afternoon a week. So it really made no sense. And so here I was saying, you guys really need to review your staff allocation and your FTE. I think trauma care starts with more than just a top-down commitment. It's more than lip service, and it's an organizational commitment. I was in Fort McMurray touring the oil sands, and they had this big banner on the wall that said, 0 fatalities, 0 injuries in 362 days. Safety is just how we do things. And that is just, I'm not a huge fan of the oil sands, I'll say, but I just thought that is absolutely brilliant. Because it speaks to a cultural change, it speaks to a systemic change. Trauma-informed care, it has to become just how we do things. And when that happens, when you have a top-down level commitment to that, and when you have every manager, director, and every person in between committed to trauma-informed care, somehow, some way, you'll get the resources to do so. You'll get extra staff, you'll get extra training. It's when we get real about becoming trauma-informed care that it becomes a reality. We talked about increased access to identification documents. AHS has actually done fantastic work with our ID program. We've gotten to our ID repository program at AHS. It's just absolutely phenomenal. We're getting people access to identification, and we're storing it in these little bank kind of things. And these are taken off in all the major cities, so it's increasing access to support, and it's ensuring people are getting health services. Ipj, so I'm still currently involved with corrections, with Justice and Solicitor General, still involved with some of their programming, some of their policy design. So what can I do? So these are property bags. They're not bags of now legal cannabis. You'll see one of them has a card there. That card is actually a referral card to an addictions and mental health staff. It has an appointment, time, and date on it. And all of these bags were found at Clairview Station in Edmonton. Why? Because 6 o'clock every morning, a big van pulls up and drops off about 20 inmates. And every one of them carry a property bag. Mostly, they have shoelaces in them. But my point is, that's not good transition planning. Setting somebody up for failure is dropping them off at a bus station without money for the bus or the train. This card, I think the spirit and intent is there, but I think it's fair to say that it wasn't very effective. We need to start looking at more effective transition and more better ways of engaging people with service delivery. That goes beyond just correctional centers and addictions and mental health. What can we do? Well, we can keep the conversation alive. Those of us who work at Alberta Health Services know not to bite the hand that feeds us, but I'm still going to say we need to challenge our health service. We need to expect it. If we're talking about patient complaints here today. I don't know how many times in these interviews somebody said, this happened to me at a hospital, it's not right. And I said, did you make a complaint? They said, no, nobody ever listens to me. And I'm like, when you don't make a complaint, when you don't make a formal complaint, nobody has to listen to you. Nobody wants to hear it. So make a complaint, advocate for those rights. And when you're working with people, help them by advocating for the rights. We have a lot of success measures, KPIs at AHS, and as long as nobody's complaining, we're just doing fantastic. And that's the truth. So we need to start advocating more. We need to challenge our health system, we need to expect more from our health system. And continue to ask leadership about service enhancements pertaining to Indigenous people. If we don't start putting pressure in these positions of power, it's going to happen a lot slower than it has to. That concludes my presentation for today.